Good morning, everyone. Thank you very much for coming today to our luncheon series. This is session 2B, so thank you for joining us for our first two. Today we have our speaker, Ms. Lisa Pilon. She's the Director, Activity and Costing Finance at Alberta Health Services. You heard from her last week. This week she's going to speak on costing again, but this time on diagnostic imaging and some other costing related items. Next week we have session 3. As you know, that session will take place at Grant MacEwan. We do have a ETS bus that we've commissioned to take you there if you would like to catch a ride over to Grant MacEwan if the walk is a little bit too long for you. So Hannah sent out information about the shuttle bus, so if you have any questions about it, please feel free to ask Hannah or myself, and we'd be happy to answer it for you. And otherwise, I will give the floor to Ms. Pilon.
Thank you, Jasmine. So thanks everyone for inviting me here today. So the topic for today is an orientation on costing for diagnostic imaging. And it's actually a very timely topic because it's something that we're looking a little bit closer at AHS as well. So this was very timely. So diagnostic imaging costing. I guess I wanted to start first with, this is kind of where I had to start when I started this, is what is diagnostic imaging? So down to its basic of what is it. So we talk in terms of different language. I'm sure you guys know it as much as I do. We talk in terms of what we call modality. So modality is where you'd have an x-ray. That would be the terminology for modality. Then we have what we call CPELs, Common Procedure Examination Lists. And that's where a modality like an x-ray will be broken down into a head, a chest, or a spine x-ray. A little louder? Thank you. And so that's kind of where we go is you'll hear the terminology modality, you'll hear the terminology CPEL codes, and there's an example of how the two break down. This is the same thing. Here's another example of modality versus a CPEL. So for an MRI, that would be what they consider costing or at a modality level. Then we have things that go even more granular, abdomen, chest, and brain. So that's another example there. And then, so what kind of costs can we or do we include in the cost of the diagnostic imaging? So, for example, the way that some of the examples that we have here is what we'd have, actually I'll start with the middle. We have what would be called the direct costs. So those are the direct costs that directly are expenses related to actually doing an exam or a test. Examples of those would of course be your labor, your supplies. We include things like the depreciation on the equipment that you do to do the test, medical interpretation fees. We would include in there drugs, portering, and transcription. Then at the top, we have what we call indirect costs. So in that case, there's really two sets of indirect costs. There's site-specific costs, and those would be things that, like housekeeping, building plant maintenance. So they're at the site, but they don't necessarily are directly influencing when you actually do the test. So that's why we call them kind of site-specific indirect. Then in costing, you can have what we call corporate indirect. And that's going to be like the really big stuff. That's going to be, you know, AHS's IT, finance, purchasing, HR. That's where you kind of want to get a full cost in. So if you take your indirect costs, your direct costs, that would end up being what we call the total costs of an exam. Now, as I go through this, I had to point this out for people. So all these costs in here are for illustrative purposes only. So don't take notes and go do your economic evaluations based on that. I hate to see what you came out with. So I just thought a little word of warning there. They're all just, they're not real numbers in there. So there's really what I would call two ways to actually do costing. We'll do it for DI exams. So there is what we would call more standard average costing. And then the one that we're going to get into after that is what I would call activity-based costing. And I'm sure that you guys have probably heard some kind of terminology along those lines before. So we're really going to look at two types of costing for this. So if you look at a standard average cost, this is an example. Now I'm using the word functional center, and that's an AHS terminology. But what it really means is all the charges that go into one account code. It doesn't matter if it was an AHS system or any kind of a finance system. What you're doing is it's all the costs that are going into that account code. So for example, with a standard average cost approach, you might get all your costs into the functional center for your direct costs. And then you may choose or not choose to then load that functional center with all these overhead costs. So your direct costs might be $1 million, then you load your overheads and you might have $2 million in costs. But then you have within that all those costs of $2 million, or $1 million in this case, you've got a certain amount of tests that you're actually doing with those costs. And then a standard and average cost becomes very simple. It's basically taking your $1 million, you've done 10,000 tests, you've got $100 per test. Start doing the evaluations that you want, it's $100 per test. But it's a pretty big number because it's $100 for every test. And how close really is that? You know, how accurate is that? But that is kind of what a standard or an average costing approach would do. Now, having said that, it's not as high, it doesn't have to be as high level as you would see in terms of the example one. So for example here, this is still standard average costing, but in some cases, whether it's a functional center at AHS or any account code, you might have more than just one account code for MRIs. That's a pretty big account code. You might actually have an account code that has nuclear medicine in one of them and magnetic resonance imaging in another. And so then you wouldn't quite have $100 per test. You'd have something a little bit better. You'd have $50 a test and $30 a test. So you know your nuclear medicine tests are about $50 a test. Your magnetic resonance imaging is $30 a test, a little bit closer than $100 a test. Probably a little bit more, a little bit easier for you guys to work with. But we're still somewhat averaging them out as a standard cost. And this is where we get into what we term is a bit more activity-based costing, and ABC is what I have in brackets there. So the real difference between an approach like this is it's taking all the costs in your charges, say it's $2 million or $1 million or whatever, and then you have all these tests running through it. So for example, you might have all your x-rays going through that count code, but you have chest x-rays, you have head x-rays, you have spine x-rays. So on an average cost, you're going to put them all at $100 a test, right? So that's what average costing will do. What activity-based costing does is it takes, and in this example, we're using minutes of service. So what it's doing is it's saying within that $1,000, we've delivered 60 minutes of service. So then what we do is we know ahead of time that a chest x-ray example takes 15 minutes, and a head x-ray takes 25 minutes, and a spine x-ray takes 20. So instead of giving everyone $100 a test, you're giving them the costs based on the amount of minutes it takes to do it. So you're going to get $527 a test because it took 15 minutes. You're getting, oh, I've got this backwards. Anyway, so I'll have to fix that up on the slides. So what it should be is, if you're taking 25 minutes, your test should be more expensive. I have that a little bit backwards, I apologize. So basically, if you take the 25 minutes per test, you actually should have more like about $600. If you have 15 minutes a test, you're going to have a lower cost of $400. And if you take 20 minutes a test, you're going to have somewhere in between at like, $450. So I apologize, I'll clean up those numbers there. So the point being on that one is you have this amount of money in your functional center. Now it's not $100 a test. The test that takes more time, takes 25 minutes, is going to cost you more in that functional center than the test that takes you 15 minutes. So now we're basically saying one's more expensive based on the time it takes to actually do that test. And I saw a hand up there. I'm not sure if that was for a question.
I was just wondering, how did you arrive at $527 per test? Wouldn't that be $250?
Yeah, I apologize. I said I messed up my bottom little boxes there.
Okay.
So that was a test, okay. And you passed magnificently. Thank you very much. That was wonderful. Okay. I'll have to clean up the slide. I apologize.
Oh, okay.
Yeah, I apologize for that. Now, with activity-based costing, on top of that, And again, I'll clean up the top boxes there. But for the chest x-ray, head x-ray, and spine, for example, you might come to a cost per test. So now we've gotten a little bit more granular. We actually have a different cost for each type of test. But then on top of that, you could also have very test-specific types of cost. And for DI, a good example of that is interpretation fees. And that's where they're coming to actually interpreting the test. So there's actually a standard list of costs for interpretation fees that's used. So for example, you can even get even more activity-based costed, add the actual specific test cost to that test, and now you're going to get a little bit more. So for example, in a chest x-ray, the interpretation fee might be $20. In head x-ray, it might be $10. In spine, it might be $30. So that's a good example of where, on top of everything else that you've done, you can take, and we do that with other activity-based costing too. You might have patient-specific supplies that are very specific to a type of patient, or in this case, a type of test. So what you're really doing that is you're just making it a lot more granular, and you've got very specific costs that you can work with, say if you're doing your economic evaluations. So then I'm just going to flip up here a bit. Back to here as a reminder. So as you can see, when we did activity-based costing, we used 60 minutes, what we call 60 minutes of workload. So in that functional center, you may hear the term a lot, workload, when you hear some terminology. What workload is doing is an example when we do tests for DI, they use minutes as their workload. So they know that in terms of the $2 million in costs or 1,000, they've done 100,000 minutes worth of service, 100 minutes worth of service. So that's what they call workload. So they're taking the dollars and they're attaching a certain amount of minutes of service to those dollars. And that's how they allocate out for DI exams. That's how they get different costs for different tests. It's by using the minutes of service by test, which is what they call the workload in that functional center. So how much work have they done to create those costs? So then the question then becomes is, what is workload? So what workload is doing is it's measuring the amount of time it takes for a person to actually do a test. And then as we were showing in our prior examples, what the workload is doing is it's a way that you can allocate out the total cost in a functional center by the amount of time taken. So that's where you saw in those previous examples. In the case of diagnostic imaging, what they do is they actually have default times. So instead of someone going in there every time, so can you imagine someone going in there every time and saying, I'm going to do a chest x-ray, and actually counting and marking, okay, it took me 20 minutes today. And then someone else comes in and does a head x-ray and say, oh, it took me 17 minutes today. So what they've done instead in terms of DI is they've created what they call a standard list of default minutes. And then the way that those are created is there's provincial CPAL committees for, I think it's per every modality. So X-ray will have a committee. MRIs will have a committee. And then what they do is they set these default times. They review them. They set them, they do is they got them originally through actual time and motion studies, is how they got them originally. So they got them through time and motion studies. They don't review them. They don't have a period or a pattern that says every 3 years we're going to redo our time and motion studies. Each committee, whether it's the MRI committee or the X-ray committee, they kind of look, they're professionals, they judge whether they think it continues to be accurate or not. Whether they think they need to redo time and motion studies, they kind of make that as the clinicians, as the professionals. I don't really know how they do it. I would guess that they might do it if all of a sudden they get maybe some really technological advances or in how they deliver service and how they do a test. That to me would be an example where they might redo those time and motion studies. But it's not like they're going in and just doing them every 3 years. So now the difference there is by doing this, it's increased simplicity over actual time. So that was the example I'm saying is if you imagine a site having to go in every day and you're actually trying to test patients, and every day you do patient A and you mark down 10, and then patient B you mark down 12 minutes, and then you put all this paper into the computer and you do all this, what they've said is really, I mean, most likely the chest x-ray takes 25 minutes if we sample it. We're not going to make everyone go through and go 25 minutes and 24. So that's why default times, that kind of a method, makes less effort at sites for tracking. And it can also allow for better accuracy and less chance of data collection error. So the way that happens is you kind of think that, well, the more data we ask people to collect, the more accurate it will be. That is not necessarily always true, and you guys probably know that from your experience as well. The more detailed and more accurate you try to get, people get tired, they have other things to do. Now you're into a lot of data checking and a lot of error checking. So you kind of think it's going to be more perfect, but it doesn't always end up being more perfect. So doing estimates and default times is not necessarily a bad way to go. So that's what workload is in DI, but you'll hear that terminology workload quite a bit actually. Now, I thought this would be interesting. This is real life, actually. So these are some samples of the default minutes that are actually in place, and a sample of some of the tests that you would actually be seeing. Now, and there's lots and lots of them. What we've been doing and talking about at AHS is at what level we're looking at trying to do cost per test right now. What we were recommending is we're looking at groupings. So you may not go just to the modality level, but we may not go right to every single code, and we might start grouping them. I would think that possibly for what you guys were going to do, you probably would want to be, this is me just guessing, grouping them. It may be just too much for what you're doing to want to get down to every single little test at the very detailed level. It might just be excessive. But that will depend a lot on what you guys are trying to do with that type of information. And then, so the question, I don't know how much you guys know, but terminology CPEL codes, Common Procedure Examination List. So the one they have in Alberta is actually, they have actually Alberta codes. They are not Canadian codes. So we've had that question at the last one, is how much is this Canadian, how much is this Alberta? With the CPEL codes for DI, they're actually Alberta codes. However, having said that, they're very closely matched to CIHI codes. And I'm not sure how much many of you heard at the last one last week. CIHI being the Canadian Institute of Health Information. Their database collects a wealth of information across Canada. They have CPEL codes. Ours are closely mapped. They're more granular and they're more, but they are somewhat similar. And then, as I said before, the CPEL codes may change as new tests come in and old tests leave. And then the modalities are specifically committee related to come up with those CPEL codes, add new ones, group them, change them, and that's a common thing that they do. And then what they're asking when they go to the committees, the same thing is, are all the codes still relevant? Do the times that they have in there, do they still make sense? So in terms of costing, and this would be really whether you're standard costing or activity-based costing, is now, someone, I hope I have my mouth right, someone can point it out if I don't, is, for example, all prices, all total costs are driven by price and volume. So you can focus on the cost per, but you don't necessarily want to take away the issue about what the volume is. So there's really two key drivers when you do this full cost, is you've got your cost per, but you've got your volume. And both are a wealth of information to figure out, you know, how you're pricing things and what's going to be the cost benefit. If you're doing things, do you need to reduce the price? Do you need to streamline the volume? What do the increase in volume make you do versus an increase in price? So there's always a price volume issue that is in play when you look at your total cost. So for example, you might have the same, you might have total costs, but they might be flipped. They might be price driven or they might be volume driven. So they could be either or. A great example of that is, I was talking to someone internally probably the last week or so, and they were talking about wanting to get more granular on getting cost per test. They haven't gone there yet. They don't have enough information. However, what they're doing is they're saying, as a starting point, they're doing price and volume at a very high level. So it's not the best, but it helps people understand when they're working with the data what's impacting my total costs. So even though it's not granular, it's still useful for them because what they're trying to do is say, well, are my costs going up in my account codes? Is it going up because I'm doing more work, or is it because my costs are going up? So even though it's not really narrow data, it can still be useful in different ways depending on what you're doing. So it's important to kind of keep that in mind as well. So we get this question a lot. What costs should you include? So we've given you guys direct costs, indirect site, indirect Alberta, interpretation fees, so very specific. You got all these different costs and all these layers of costs. So which ones should you be using when you do your work? I don't have all the answers today. I've given some suggestions, but I'm quite open if people have idea of what kind of cost layers they're using and how they're using it. I'd be quite happy to hear that as well. So this is just throwing out ideas. So for example, in a direct cost, you might only use direct costs. That might help you figure out what would happen if I added more service. Well, if I added more service, I'm not going to add 2 presidents to Alberta Health Services. So I'm not going to add all that overhead because adding 3 more tests isn't going to make my costs go up. So that's an example where I would only use direct costs. You might use site direct and site indirect. For example, if you're actually adding a whole bunch of costs, so much that you think that it's going to make your portering costs go up, your transcription fees go up, your indirect supervision go up. So if you think, for example, that you have one supervisor and one supervisor can handle this much work, and now you're adding a whole bunch of tests, well, now you may want to add some indirect costs because now you've added a supervisor. So it kind of depends really what you're doing on terms of what amount of cost layers that you would like to use. Another one is when, for example, full cost, which would include your direct plus your site indirect plus your indirect. That may be an example where you want to use full cost when you actually do revenue recovery. So now you're going to go charge someone for the full cost of a test. Well, you want to make sure that you go and recover the full cost. You might be submitting a grant to the government and saying, well, we need this much money to open a new lab. Well, maybe you need full cost for that. So again, there's layers of costs, and how you choose to put those layers in really becomes what is the purpose of what you're trying to achieve in that analysis.
Lisa,
Yeah.
would capital costs be outside the scope of indirect costs?
Capital costs would actually be in the indirect overheads.
Okay.
Depreciation on a piece of equipment in the DI lab would be in their direct costs. Does that kind of make sense?
Okay, so I guess maybe what I'm thinking is, say if they've got an operating room
Okay.
to do some procedures, would that be included in there, or would that be?
That would be included in your overhead.
Okay.
Now, the equipment that's in the operating room to maybe do the procedure, that would be included in your direct.
Okay.
Does that kind of make sense?
I think,
Okay.
That
Yeah.
makes sense to me.
Okay. Does anyone else have any examples of how they use different layers of costs or what they're doing with them? No pressure, I just thought I would ask. Then I could add it to my slides later. So micro activity-based costing versus macro standard average costing. So this is a little bit just a comparison of the two, big picture after everything that we've gone through. So micro, it increases your understanding of cost for each test, which could help you make better decisions. So you see all the granularity. You're getting down to actually, I know the cost of a test at the very granular level. As an example, I was talking to someone last week, and they're using the data at a granular level because they're trying to really maybe make change in their department. They say, well, that's nice. I understand I have all these minutes, and I understand the cost of all these tests. but how is it really helping me? If I really know that these 3 tests cost me this much, and these 10 tests cost me this much, and I can replace 4 of these tests with 2 of these tests, and wow, that really helps save me some money, but I'm not impacting the patient, well, that really helps me make a good decision. Macro costing at the high level may not really be able to help you make that type of decision. If you really want to get into the real detail and decide, I'm going to replace these 10 tests with these 5 tests. So average may not give you as much as what you need. More detailed costs needs more data collection. It needs more work. It's increased work to actually put the cost together, as you can probably see just from the examples of how all those layers are built. Macro gives you quicker turnaround time. You might not wait 2 or 3 months. It may just be less costly for the organization as a whole, and it may just not be worth producing. And that will come down to what's the cost benefit of producing data versus how are you going to use it. So more rich in data, that is quicker turnaround, less costly to an organization most likely. Micro and standard can be subject to higher chance of error. In some ways it can be a bit of a distraction to decision making. So if you look at a cost per test and you're looking at them for 10 sites, and one site seems significantly different, or actually it's not a good example. Say if you have all your direct costs, and now you look at your overhead costs, and your overhead costs in 10 sites look really good, and your overhead costs in another one don't really look good. Lots of times the variation could just be that the data wasn't that great. And then you're spending all this time distracting yourself from maybe looking at overheads and trying to find out why the variation in overheads is no good, when really an average cost would have done you just as good. So that's something to keep in mind, is at what level do you need to do that? Sometimes if you get really tiny, then it can just end up being a distraction, and 2 weeks later you're still trying to figure out why it's wrong, and in the end it really didn't matter because average would have just been as good. And again, just the macro of that looks on average, detailed errors won't matter as much. Now, how can you solve some of this? In the micro standard costing world, you can use default times, samples, and estimates. You can quickly validate and kick out what you may consider to be bad data. There's different ways to do it. And with the macro costing, you're really just using higher level estimates is what you're doing. So some suggestions, ideas on how can this information be used. We're talking a lot about using it, and you guys may be doing the same thing. I call it clinical pathway work. It's really, in mapping a patient through the journey, through their whole patient journey. You can use it to see that that patient had 10 tests. They went to emergency, and they went in with a headache, and they got 10 tests. And someone else went to another emergency, and they had a headache, and they had 2 tests. So you can see how much those costs per test were for one patient versus another, and can you actually streamline that service delivery so really they all only need 3 tests. So it can help you figure out as you take a patient through the journey what those actual costs are of all those services that patient gets along the way. It can help you evaluate the impact of increasing or decreasing service or service delivery. So am I going to expand a unit and I'm going to decrease the amount of tests? If I decide that I'm going to create a standard service delivery that when someone comes in for asthma, they only get, 1 test versus the variation that you might see now, what kind of an impact on the cost side is that going to have in terms of decreasing your costs? You can use it for benchmarking. You can compare variations on costs of same test across the site. So you might have 10 sites. You might see them all having the same test. You might see one site that has a really significantly more cost on that one test. You can use them to benchmark and get them into a bit more of a common practice. You can use them for contract reviews. For example, if you're out going and negotiating a contract, you might have a good idea of what your cost pers are right now. It could be a wealth of information for actually going out and doing contract negotiations. And many other reasons that information can be used. We've had a bit of discussion. You can use them possibly for your physicians. If you started advertising the tests and the physicians knew how many tests they ordered, would that transparency help them understand better? You have physician A maybe ordering 10 tests of that test, physician B is ordering 5. And if the physician saw that they were ordering 10 and it cost this much, and they were ordering 5 and it cost this much, potentially that could help improve or change behavior. Lots of times transparency of costs can do that. So then other considerations, things to keep in mind when you're looking at any of the type of information and you're getting costs. Important to understand the methodology, the terminology, the definitions. So it's good to understand the methodology behind it. What kind of costs are being included? What aren't? So do they have direct costs in there? If so, the gentleman's question at the back, is those capital costs of the building? Is that equipment depreciation? All the good things to know. If the reports are out properly, they probably should come with good data definitions and terminologies and descriptions of what's in and what's out. So good to kind of read them and get an understanding of that, especially if you're going to use them not just to do evaluations, but if you're going to start comparing. You don't necessarily want to compare something in Canada over here for a cost per DI and something over here and find out they're two completely different cost structures underneath. Same with benchmarking. Are the underlying costs the same? Is the underlying methodology the same? And then important, of course, to note is cost is one factor. Linking to patient outcomes and quality should be the driving force. So for example, when I use an example that says, let's put them out transparent, and Dr. A has 10 tests and Dr. B is ordering 5, well, we're not going to say, Dr. A, cut your test to 5 because we need to get all the tests to 5 if the outcomes suffer. So again, cost is not the driver of what should be happening here. This is about patient quality and patient outcomes, but understanding your underlying cost structures can go significantly to improving cost structure, understanding doing your evaluations, but balancing that with outcomes and quality, of course. Now, that's all I had for that, but I have a few more minutes, and what I did is I thought I would just do this first. We're doing some work on lab tests, so I just wanted to throw this in, and just for you guys to get your mind around, everything that I really talked about there, the principles are significantly the same when you go for a cost per lab test. They use modalities, they use CPEL codes. You can use a cost per, you can use standard average costing for a lab test, you can use activity-based costing for a lab test. So a cost per lab it's really following the same principles. The only really difference that we have at AHS is where you saw, for example, workload by default minutes. What we tend to see more in the systems at the lab tests in Alberta is more what I would call, and you guys probably know this terminology, weighted or relative values. So for example, they may not use minutes of service, but they might use something that looks a little bit more like this, where what they're doing is they have a functional center, and you might have test A has a relative value of 1, test B 2, test B 3, test C 3. So for example, what that really means is with a relative value of 3, it costs 3 times as much than test 1, and with a relative value of 2, it costs twice as much as test 1. It's accomplishing the same thing as a default minute, but the relative value or relative value unit is also a terminology that you may use or hear that actually helps and split out those costs as well. So very similar principles. You can apply all these principles to lab tests. You can apply them to allocating out a lot of different costs, whether you need some kind of an allocation with relative value minutes. We allocate costs of overheads on things like, things like caretaking, for example, goes out on net square meters, right? So you can use very different types of allocations, whatever you think represents most what the activity is going to be happening. And that's really all I had, but I'm very much open to questions.
Thank you. Thank you very much, Ms. Pilon. We are now going to thank you for everyone for coming today, and thank you to our online audience for coming in or tuning in today. We are going to cut our online portion of this program.